Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our esteemed toxicologists, Dr. Marlis Gnirke. Marlis completed her residency and toxicology fellowship with us here at NYU in Bellevue and continues with us as an assistant professor of emergency medicine and toxicology. It's great to have you with us, Marlis.
Thanks for having me, Brian. It's a pleasure to be here.
So we've produced over 200 episodes, but we've yet to cover acetaminophen toxicity, but the day has come for us to dissect this crucial topic. So let's start with the foundation here. We all know what Tylenol is, but why is its toxicity so prevalent in clinical practice?
So thank you for leading me right into one of the first points I want to make, acetaminophen versus Tylenol. You just mentioned both. Tylenol is a well-known brand name for acetaminophen, but if we were to only ask patients if they took Tylenol, we would be missing a lot of acetaminophen toxicity. Why? Not only is there generic brand acetaminophen, or paracetamol if you are outside of the US, Canada, or Japan, but acetaminophen is found in many combination products and other well-known brand names. To name a few, Excedrin, which is acetaminophen, aspirin, and caffeine; Fioricet, which is acetaminophen, butalbital, and caffeine; Percocet, which is acetaminophen and oxycodone; and Dayquil and NyQuil, which are acetaminophen, dextromethorphan, and phenylephrine and doxylamine, respectively. To make things even more confusing, some products have various versions. For example, a patient might say they took Benadryl, and you would be thinking about diphenhydramine toxicity, but really they took Benadryl allergy and sinus headache, which contains acetaminophen in addition to diphenhydramine. And if a patient told you they took Robitussin, you would be correct to think about dextromethorphan toxicity, but maybe they took Robitussin severe multisystem cough, cold, and flu, which contains acetaminophen in addition to dextromethorphan and guaifenesin. So the point being, it's much more comprehensive and precise to talk about acetaminophen toxicity than Tylenol toxicity. And it's the very same factors underlying this precision and language soapbox that answer your question about prevalence in clinical practice. The widespread and under-recognized availability of acetaminophen make it such a prevalent overdose. For example, as I just mentioned, acetaminophen is found in many cough and cold products. It's easy to imagine a patient with the flu taking multiple different medications to treat their fever, body aches, and cough. And despite following the correct dosing instructions for each individual product, they are unintentionally overdosing on acetaminophen because each product contains some. Acetaminophen in many of those combination products I just mentioned are also available over the counter. So there's no prescription barrier, which not only means widespread access, but may also impart a false sense of safety. Patients do not realize this potentially significant toxicity from acetaminophen, have a bad toothache, pop a few acetaminophen every few hours for a few days, and come in with hepatotoxicity.
Very good, Marlis. And Tylenol, like you said, is pretty much everywhere. When we walk down the cold and sinus aisle of our pharmacies, it's there in multiple formulations. It's easily accessible and in large quantities. And so this all contributes to the prevalence of overdose. Now, we can't have an episode on acetaminophen toxicity without touching on its pharmacokinetics and how they impact toxicity. So can you outline this for us?
Yes, the pharmacokinetics of acetaminophen are key to understanding the pathophysiology of acetaminophen toxicity. And what I want to focus on now is metabolism specifically. So let's start with what happens in therapeutic dosing. After absorption, 90% of acetaminophen undergoes hepatic conjugations with glucuronide and sulfate to form inactive, harmless metabolites which are eliminated in the urine. A small fraction, less than 5%, of acetaminophen is eliminated in the urine unchanged. The remaining fraction, which is about 5% in therapeutic dosing, is oxidized by CYP2E1 to N-acetyl-B-benzoquinone aka NAPQI, which is hepatotoxic. Thankfully, our body has a way to detoxify NAPQI, which is glutathione. Glutathione combines with NAPQI to form non-toxic conjugates that are eliminated in the urine. So all the acetaminophen we took ends up as something harmless in the urine, and everything is okay. Now, in overdose, things are a little different. In acetaminophen overdose, the amount of NAPQI formed is increased, and not just because there is more acetaminophen. The amount of NAPQI formed is increased out of proportion to the acetaminophen dose. Instead of only 5% going down that oxidation pathway to form NAPQI, it's much more, 20 to 50%. Why? Because the non-toxic sulfation pathway is saturated, and the glucuronidation metabolism can only increase so much. Okay, so we make more NAPQI. But we just said we have a way to take care of NAPQI. Can't we just detoxify it all? Unfortunately, there is also only so much glutathione. The rate and quantity of NAPQI formation outstrips our glutathione supply, resulting in NAPQI being released within the cell rather than being eliminated as something harmless in the urine. Unleashed in the hepatocyte, NAPQI binds proteins and induces a series of events, resulting in hepatocyte cell death. Hepatotoxicity initially and most profoundly occurs in zone 3, also known as central lobular, because this is the area of the liver with the largest concentration of oxidative metabolism. So that CYP2E1 pathway making NAPQI that we discussed. In severe cases, zones 2 and 1 will also be affected, and the entire liver parenchyma will be destroyed. So understanding acetaminophen pharmacokinetics helps us understand the pathophysiology of liver injury. And this is also a good example of a broader theme in toxicology, which is that toxicokinetics differ from pharmacokinetics. Things behave differently in overdose.
Okay, so a lot there, but basically acetaminophen overdose leads to excessive NAPQI formation that depletes our glutathione and causes liver cell death, especially in zone 3, but this could spill over to 1 and 2. Now, that's what is going on at the molecular and cellular level. Tell us about what we see clinically.
So the clinical course of acute acetaminophen toxicity is typically divided into 4 stages. In stage 1, patients are often asymptomatic, or may have vague, nonspecific symptoms like nausea, vomiting, and malaise. Hepatic injury has not occurred yet. Acetaminophen is being absorbed and metabolized, but it takes time to saturate that non-toxic metabolism and deplete glutathione. This clinically silent initial stage is why acetaminophen is the most important tox lab to send. The tox lab trio is acetaminophen, aspirin, and ethanol, but really, aspirin and ethanol toxicity should be clinically obvious. Acetaminophen toxicity, on the other hand, will not be clinically obvious until much later, way after you should have started treatment. The only exception to this stage being clinically silent or subtle is massive overdoses, in which patients may present with early symptoms of decreased consciousness and metabolic acidosis with elevated lactate, which is due to inhibition of the electron transport chain by acetaminophen, NAPQI, or both. But most patients, even ones who will go on to become sick, are going to be asymptomatic during stage 1. Okay. So that's stage 1, on to stage 2. Stage 2 represents the onset of hepatic injury. As hepatocytes necrose, they will release, among other things, AST and ALT. AST specifically is the most sensitive marker as it rises before ALT. Abnormalities in AST and ALT represent hepatic injury and precede evidence of actual hepatic dysfunction. Stage 2 most commonly begins within 24 hours and nearly universally by 36 hours after ingestion. In massive overdoses, hepatotoxicity may start a little earlier, as early as 12 hours post-ingestion. Signs and symptoms in stage 2 can vary, depending on the severity of hepatic injury. You may have some right upper quadrant pain, but oftentimes this can also be clinically silent. Stage 3 represents the time of maximal hepatotoxicity. This occurs 72 to 96 hours post-ingestion. Enough liver cells have necrosed that you get hepatic dysfunction and failure. So this is when things stop being clinically silent. Patients will be very symptomatic. AST and ALT are often above 10,000, but what we care about more here are markers of hepatic dysfunction rather than just hepatic injury. So abnormalities of PT-INR, pH, creatinine, lactate, phosphate, and hepatic encephalopathy are the critical determinants of prognosis here, and much more important than the degree of aminotransferase elevation. Fatalities typically occur between 3 to 5 days after acute overdose due to hepatic and/or multi-organ failure. If patients do not die, they reach stage 4, which is the recovery phase. Usually this happens over the next week or so, but it may take longer in severe cases. Of note, survivors have complete hepatic regeneration. No cases of chronic hepatic dysfunction are reported. The liver has remarkable regenerative capability, so if you survive, you will not have long-term damage, which is pretty amazing.
Perfect. So these are the 4 stages of acetaminophen toxicity, and we must note that many are clinically silent, right? Highlighting the importance of being diligent with our history gathering and not forgetting to check that Tylenol level when appropriate. So Marlis, tell us what we can do to help our patients survive. Tell us about the antidote.
So the antidote for acetaminophen toxicity is N-acetylcysteine, also known as NAC. NAC works in a variety of ways. Early after ingestion, as acetaminophen is being metabolized to NAPQI, NAC prevents toxicity by limiting the formation of NAPQI. It serves as a glutathione precursor and substitute, combining with NAPQI and converting it to harmless conjugates we can pee out. So basically, doing what the body does in therapeutic overdoses, but since the endogenous supply was exhausted by that excess formation of NAPQI, we replenished glutathione in the form of NAC. NAC also supplies substrate for sulfation, which allows more acetaminophen to be metabolized by that harmless pathway instead of to NAPQI. So this is a preventative role of NAC and represents an important window of opportunity, which we will come back to. Now, even once NAPQI has formed and started to bind proteins and cause badness in the hepatocyte, NAC reverses some of the harmful effects and diminishes hepatocyte injury. So, even if you miss the window of opportunity and a patient presents late, NAC is still helpful. And finally, even in fulminant liver failure, NAC decreases the incidence of cerebral edema and death through nonspecific mechanisms such as free radical scavenging and antioxidant effects that preserve multi-organ function. In fact, you will often see NAC given in non-acetaminophen-induced liver failure. It just helps failing livers and failing other organs.
Okay, so that's NAC and how it replenishes glutathione and aids in preventing liver damage, even in severe cases of toxicity. Now it's time to talk about how we determine who needs this treatment. So tell us about the Rumack-Matthew nomogram and its role in clinical decision-making here.
The nomogram is a tool to help us decide who needs antidotal treatment. So it was developed by two toxicologists, Barry Rumack and Henry Matthew. Essentially, they looked at a data set of untreated patients who had acutely overdosed on acetaminophen and looked whether or not they developed hepatotoxicity, which they defined as AST greater than 1,000. For each patient, they plotted initial acetaminophen concentration versus time since ingestion, and then drew a discriminatory line to separate patients who developed hepatotoxicity from those who did not. This line is what became known as the treatment line. Patients that fall above the line are considered at risk of developing hepatotoxicity and therefore warrant treatment. Patients who fall below the line are not at risk and do not need treatment. So it's a wonderful tool. You just need one acetaminophen concentration and the time of ingestion. Now, the nomogram can only be used for risk determination in acute acetaminophen overdose. Technically, this refers to a single ingestion. However, for nomogram purposes, most toxicologists will extend this definition to overdoses in which the entire ingestion occurs within a 4-hour window. For your time of ingestion, you should use the earliest possible time. Or if you are plotting an ingestion that occurred over 4 hours, use the start of that time window. Why? Because this is the worst case scenario. If you look at the nomogram, you will see the treatment line is a downsloping line starting at 150 micrograms per ml at 4 hours. The more time that passes since the time of ingestion, or the farther right you go on the x-axis, the lower the serum concentration you need to be considered treatable. This makes sense because the serum concentration will decrease with time from ingestion as acetaminophen is metabolized. But we know that it's being metabolized to the harmful NAPQI. So the later from time of ingestion that you're catching a patient, the lower the acetaminophen concentration corresponding to a risk of hepatotoxicity and warranting treatment. That said, I want to highlight again that this line was developed from empirical and not from pharmacokinetic data. The slope is derived from patients and clinical outcomes and one initial acetaminophen concentration, not from acetaminophen half-life. This helps us remember a few important things. First, since it was designed using a single acetaminophen concentration, we should also make our decision to treat or not based on one acetaminophen concentration. The only potential exceptions where you might get a second concentration to help you make your decision are ingestions of extended-release acetaminophen or co-ingestion of anticholinergics or opioids, which would slow the gut and could lead to delayed or prolonged absorption. Otherwise, one concentration to make your decision whether or not to treat. Second, since the nomogram was derived from real patients, it also accounts for many real-world situations. What if my patient lied and actually took the acetaminophen 20 minutes earlier? To quote a mentor and the actually esteemed toxicologist Bob Huffman, all the lies that people tell are already built into the nomogram, because it's based on real people empiric data. In fact, as some additional reassurance and buffer for real-world errors, we also have a built-in margin of safety. The treatment line we use in the US was lowered by 25% from the original line to increase sensitivity. So this is a sensitive risk assessment screening tool, as screening tools should be. Why does a nomogram start at 4 hours? This comes back to pharmacokinetics, to a part I skipped before. Absorption. You need to allow time for complete absorption before you measure the serum acetaminophen to know what you're dealing with. If you measure before 2 hours, absorption is not complete, and you could still absorb enough to put you over the line at 4 hours. Absorption has already occurred to some degree between 2 and 4 hours, but a detectable concentration is uninterpretable. Are you on the way up or down? You could have a 3-hour concentration of, say, 200 that falls to below 150 at 4 hours, and you don't need to treat. Or you could have a 3-hour concentration that's on its way up to 400 at 4 hours, and you definitely need to treat. So this is why the nomogram starts at 4 hours and why you really want to make your decision on a concentration drawn from at least 4 hours from time of ingestion. And the good thing is, you have a little time. This comes back to that window of opportunity I mentioned. NAC is nearly 100% effective if started before 8 hours of ingestion. So if your patient is coming in early after ingestion, it's okay to wait and get the proper 4-hour level to make your decision. On that same note, if your patient is coming in later, either beyond 8 hours or say at 7 hours and you know it'll take a little longer than 1 hour to get the lab result, you should start NAC while waiting for that result. Once you get your result, you can stop it if the value is below the treatment line or continue it if it ends up being above. But it's important to get the antidote in before 8 hours, during that window of potential prevention, if possible, or as soon as possible thereafter, if not. The nomogram only goes to 24 hours. What if your patient comes in later than this after an acute overdose? How do you decide whether or not to treat? In this case, a detectable acetaminophen concentration or an elevated AST are indications to treat. Why? Conceptually, for a patient to have a detectable acetaminophen concentration that far out, they must have had a concerningly high initial concentration. If they have an elevated AST, that means hepatotoxicity has started. Even if their acetaminophen is now undetectable because it's all been metabolized, if AST is elevated, start NAC. Now, what about chronic overdoses, or as they are better termed, repeat supertherapeutic ingestions? Patients who are repeatedly taking too much acetaminophen, for example, that toothache patient. We cannot apply the nomogram for chronic overdoses because we don't have a single time of ingestion to plot. We have many repeated times of ingestion. So we use an approach that's conceptually similar to the approach to late presenters that we just described. If they have an elevated AST, start treatment because this indicates hepatic injury has started. If the AST is normal, but they have a detectable acetaminophen, start treatment because they have been repeatedly overingesting, their glutathione supplies are depleted, and even that small amount of acetaminophen has the potential to cause hepatotoxicity. Now, this is a general conceptual framework. There are many case-by-case nuances, so please call your local toxicologist, but that's the general approach to risk determination in cases where we cannot apply the nomogram.
This is great. This touches on a couple of the points that I think a lot of us have beyond the straightforward application of the nomogram, like late presenters and chronic overdoses. Now, Marlis, once we've identified a patient who requires NAC, what is the recommended protocol for administering it in overdose cases?
NAC can be given PO or IV, and there are several different protocols. With the exception of fulminant hepatic failure, for which only the IV route has been studied, IV and PO NAC are thought to be equally efficacious. The main downside of PO administration is a higher rate of nausea and vomiting, which is understandable given that it tastes and smells like rotten eggs. Also, the patient has to actively and repeatedly drink something as opposed to just passively receive an IV. So typically, patients are going to be started on IV NAC. The standard protocol is the 21-hour 3-bag IV NAC protocol. The 3 bags refer to 3 different concentrations of NAC. The first bag is the loading dose, 150 mg per kg over 1 hour. The second bag is 50 mg per kg run over 4 hours, which comes out to 12.5 mg per kg per hour. And the third bag is 100 mg per kg run over 16 hours, which comes out to 6.25 mg per kg per hour. So 21 hours in total. The main downside of IV NAC is a higher rate of anaphylactoid reaction, better termed a non-immune hypersensitivity reaction. This is caused by a non-IgE-mediated release of histamine from mast cells and monos. Most reactions are mild and include flushing, urticaria, nausea, and vomiting, but rarely they can be more severe and include respiratory symptoms or hypotension. In fact, acetaminophen actually inhibits mast cell histamine release, so a higher acetaminophen concentration decreases the risk of an anaphylactoid reaction. And conversely, patients with lower acetaminophen concentration are at greater risk of developing an anaphylactoid reaction. Reactions are also going to be rate-related, so they will typically occur during the loading dose. If your patient develops an anaphylactoid reaction, call the poison center and we will guide you through management. Essentially, mild reactions such as flushing do not need any treatment or NAC adjustment. If urticaria, angioedema, or respiratory symptoms occur, hold the NAC and treat your patient with diphenhydramine, plus steroids and epinephrine respectively. But you can actually usually restart the NAC again without recurrence. Just start it at a lower rate initially. If the reaction was scary, the safest thing to do is to switch to PO, because anaphylactoid reactions have not been reported with PO NAC. Now, we call this a 21-hour protocol, and some patients are indeed done after 21 hours, but it's important to note that some patients will need extension of the protocol beyond 21 hours. Conceptually, you should continue NAC until the risk of toxicity and toxicity, if it developed, are gone. What does that mean? In brief, you want an undetectable acetaminophen, a significant decrease in AST if it was elevated, and no evidence of hepatic failure. The undetectable acetaminophen criterion is easy. If your patient still has acetaminophen on board, that's more NAPQI that can be made, so NAC should be continued. The AST criterion is variably defined. I usually want an AST that is decreased to under 1,000. Recent consensus guidelines recommend a percent drop of 25 to 50% from peak rather than a hard cutoff, which is also reasonable. Talk it over with your local toxicologist, but however you define it, you want a clear downtrend and a significant decrease. If your AST was never increased, then great. It should stay that way in order to stop NAC. If it's going up, that indicates that hepatic injury has started, so you should continue NAC. The final criterion is no evidence of liver failure, because if you're having liver failure, then you're clearly not out of the woods. So in order to decide if the standard 21-hour NAC protocol needs to be extended, you will need to draw labs before the end of the 21 hours. I usually recommend around 19 hours to allow time for those labs to result. You don't want to wait until after the NAC has run out to realize that everything's going in the wrong direction and you need to continue NAC, and now the patient hasn't had NAC in a while. If a patient doesn't meet stopping criteria at the end of the 21-hour protocol, how do you go about continuing NAC? You just continue it at that third bag rate, the 6.25 mg per kg per hour, until they do, or until transplant or death. So I mentioned before there are multiple IV protocols. We don't have time to delve into all of them, but I will mention one somewhat common modification of the 21-hour protocol, what we call double dose NAC. So in cases of massive ingestion, there's sometimes concern that the traditional 21-hour protocol will not provide enough NAC to detoxify all the NAPQI produced on a mole-to-mole basis. So the second bag dose is continued for the duration of the protocol rather than switching to the third dose bag. Remember, the second bag is twice the concentration of the third, so that's why it's called double dose. Massive is going to be variably defined from toxicologist to toxicologist, but you may see it recommended for 4-hour concentrations that are over 300 or 500.
Now, Marlis, taking a step back, you mentioned monitoring acetaminophen and AST levels to guide our treatment decisions. What are the other labs we should be getting to manage these patients effectively?
So in patients demonstrating hepatic injury, you're going to want to trend labs that make up the so-called King's College criteria. These were originally developed to identify patients who need liver transplant. However, they have since morphed into criteria to transfer a patient to a transplant center if they are not already at one. The specific criteria are pH under 7.3, INR greater than 6.5, creatinine greater than 3.4, grade 3 or 4 hepatic encephalopathy, and then some modified ones, lactate greater than 3.5 and phosphate greater than 3.75. These are on MD Calc for easy reference. So in addition to serum acetaminophen and LFTs, send serial BMP, phosphate, and blood gas with lactate.
Okay, very good. And we'll also have this in the show notes. So that's adults. Now tell us what considerations we should keep in mind when we're treating pediatric patients.
The main consideration to highlight is that the volume of NAC can be an issue in neonates, and so it needs to be concentrated. So make sure to speak with your pharmacist and concentrate it. There are specific recommendations for preparation in the package insert or in Goldfrank's Antidotes in Depth chapter.
Okay, and before we close out, this is such an essential topic in toxicology and emergency medicine that, as the story goes, started off with the drafting of a nomogram on a bar napkin. But, that was then, and this is now. Tell us about what has changed in the past couple of years, and is there anything new on the horizon we should keep a lookout for?
So one thing I want to mention is IV acetaminophen, which is newer than oral formulations, and therefore experience is comparatively limited. So while pharmacokinetically, you would actually think IV is safer than PO because it's skipping first-pass metabolism, which happens in the liver, there is just less experience and less data. So as of right now, the recommendation is not to apply the nomogram. And in fact, you would treat acute exposures to a lower mg per kg of IV than you would worry about for PO. So just something I want to highlight to make everyone aware of as we see more IV acetaminophen on hospital formularies. Hopefully, we will also gain more insight and experience to guide management. The other thing I want to mention, which I can only touch upon for the sake of time and my sanity, but I would be remiss not to mention, is fomepizole. You may see or hear about fomepizole being used for acetaminophen toxicity, and you may wonder why. We are familiar with fomepizole for treatment of toxic alcohols via alcohol dehydrogenase blockade, but where would this come into play in acetaminophen? So fomepizole is known to be a CYP2E1 inhibitor, which we know is the enzyme that oxidizes acetaminophen to NAPQI, the hepatotoxic metabolite. So this is a theoretical argument for giving fomepizole early in massive overdoses before NAPQI formation has started. Preclinical studies also suggest that fomepizole inhibits JNK, which is a kinase involved in the oxidative stress cycle that is set into motion by NAPQI, which causes hepatocyte injury. So this is a theoretical argument for giving fomepizole late in massive overdoses, after NAPQI formation has already occurred. This is a big can of worms, and the long and short of it is that we are still missing human data to support this. And furthermore, most patients do fine with NAC, so is it even necessary? But the preclinical data is certainly intriguing, and human studies are underway, so stay tuned.
Marlis, thank you. We've made it through this hefty topic and we've preserved your sanity in so doing. Now let's go over some take-home points. Acetaminophen toxicity is common because in part of its presence in numerous over-the-counter and prescription medications, not just Tylenol. So it's crucial to ask patients about all medications taken to accurately assess potential overdose risks. In an overdose, acetaminophen's usual metabolic pathways become saturated, leading to increased production of the toxic metabolite NAPQI, which depletes glutathione and causes hepatocyte death. This is going to progress through 4 clinical stages, often starting with clinically silent periods, and this emphasizes the importance of measuring acetaminophen levels even when patients are asymptomatic or you have an inkling that the patient might have overdosed to ensure timely treatment. NAC is the antidote here, and it replenishes glutathione stores and can prevent or mitigate liver damage if administered promptly, ideally within an 8-hour window after ingestion. Now, the Rumack-Matthew nomogram is a vital tool for determining the need for NAC treatment based on serum acetaminophen levels and the time since ingestion. However, it does have its limitations in late presenters and chronic overdoses, so we should be using our clinical judgment and consulting our friendly toxicologists. Now, management may require extending NAC therapy beyond the standard 21-hour protocol, and we have to keep an eye out for anaphylactoid reactions and keep in mind that we should be monitoring for signs of hepatic failure using tools like the King's College criteria to determine the need for transplant evaluation. Now, lastly, in cases of massive acetaminophen overdose, modifications to the standard NAC protocol, such as a double-dose NAC regimen, may be necessary to ensure adequate detoxification of NAPQI, and this again underscores the importance of individualized treatment plans for these patients and calling our poison control centers. Okay, deep breath. Marlis, thanks again for being here and going over this essential topic and touching on all those critical points and nuances that we should all keep in mind.
Thanks so much for having me, Brian.